In this scenario, we drop in on a family care conference taking place in a skilled nursing facility. A nurse and a social worker are discussing POLST with two adult children of an elderly patient with advanced Alzheimer's disease. One child is the patient's legally recognized decision maker and the other is not, and they have different opinions about what their father would want. The nurse and the social worker explore the wishes of the patient and they refer to the patient's advanced healthcare directive for clarification. They make up a follow-up plan for the siblings to also meet with the patient's physician to discuss their concerns.
Good morning. It's nice to see you again.
Good to see you again.
Nice to see you. Hi, my name's Catherine.
Hello, Ruby.
I'm the case manager.
Hi, Kathy.
Overseeing the care of your dad. And I'm
Nice
so
to meet
glad
you.
you're here. I know it's been a long time for you to be able to get here from Atlanta, a long journey. But I'm
Yes,
glad
it was
you're
a
here.
long flight.
Very important.
Hi JT, good to see you again. My name's Jason O'Donnell. I'm a
Hi,
medical
Jason.
social worker. Nice to have you here. Thanks for coming all the way.
Thank you.
We routinely have these care conferences so that we can look over the plans of care that each one of our residents here at the facility has. And in particular, when people have a change in condition, when we see things aren't a little different than what they were maybe a month or 2 months ago, we want to make sure that the family understands the things that are going on and to review plans of care, review goals of care. And you know, your dad was an amazing man, and when he came to the facility here, he brought an advance directive, and everything was in order, and he was very explicit about the things that he wanted and what he didn't want. And so we wanted to review that, and part of our care conference is focused on taking the wishes that are somewhat vague in an advance directive and making them more explicit on a document that we have here called Physician's Orders for Life-Sustaining Treatment. So currently on the record we have, in the event that your dad's heart and lungs didn't work anymore and that he had died a natural death, we were to not make any attempts to do cardiopulmonary resuscitation.
That's right.
And that
None
was
at all?
none.
No, he has a DNR. He has a do not resuscitate order.
No. I want him, if that comes to pass, I want him to have CPR.
But those aren't his wishes. Ruby, you weren't around when we talked about this. Dad and I talked about this before we came to the facility.
No, I can't imagine. You want to kill our daddy?
It's not about killing. It's that we're letting nature take its course. If his heart stops, he doesn't want it restarted. If his heart stops, it's time for him to go. We talked about it, Ruby.
No, I want intervention if something happens.
Well, let me ask you, Ruby, tell me what you understand about CPR.
Well, I've seen it on TV. I've never seen it in person, but I've seen it plenty of times on TV, and there's seems to be a good success rate when it's depicted there. And so that's what I want for our daddy.
And typically on television, there is a very good success rate. In the skilled nursing facility, people are more frail and they're more elderly, and we don't have all the equipment that they do on television or in hospitals to be able to implement an attempt at cardiopulmonary resuscitation intervention immediately. So it's a very different environment, very, very, very different environment.
It's not like he's living in an ER.
Right.
Well, I realize that, JT.
So I would like to give you some information about cardiopulmonary resuscitation, okay? And it's a very informative document that you can read and further discuss. But what we do currently have on his chart, per his explicit instructions, is no attempt to resuscitate.
Well, and I think it's important for you guys both to understand what happens in CPR. It's truly a heroic procedure. I mean, there really are in those emergency rooms really trying to bring somebody back who, clinically speaking, they've died.
Exactly.
And it's truly heroic. And the unfortunate thing is that it's actually not very successful. And in a condition like your father's condition, it's even less successful than the general population. Somebody with an advanced Alzheimer's disease who may have other disease processes and who's in advanced years. There's not it's not real likely that we can bring people back successfully with CPR. Our role is really to provide education to make sure that that you understand what you're asking for.
He doesn't want to see himself go through the CPR. Your mom had CPR, and it was very damaging, and Dad was there. It was horrible.
Well, I don't know. I'm just not ready to agree with you at this time, JT. I'm really not.
Well,
It's very difficult.
This is something that he has put me in charge of because he understands that we've had these discussions, and he understands I have a little bit more of a level head. You'll always be his daughter. You'll always be his baby girl.
Yes, I am. And I want to have a say in this.
And he has, by virtue of completing the advance directive, declared that these are his wishes, and we're obligated to follow those wishes should a catastrophic event happen.
Well, you've addressed CPR. Are there any other life-saving things that you've talked about
Well,
that I
this-
don't know about?
This is something we haven't discussed yet because I didn't want to worry you on the plane, but he stopped eating.
You did?
Yeah, he's refusing to eat now.
So what are you doing?
We're allowing him to not eat. Those are his wishes.
Aren't there other options?
There are other options. There are options that are very aggressive, and then there are options that are less aggressive. The very aggressive options is that, and you can talk further with your physician about this, about putting feeding tubes in the stomach or in the nose to provide artificial nutrition. Or there are the options of changing the consistency of the diet so that eating and swallowing becomes a little bit easier. And then there's the less aggressive, even though very effective, intervention where you just do very, very aggressive mouth care so that the mouth feels very clean and it feels like it's satiated, and it's and their dentures or their natural teeth are well cleansed, and allowing that natural progression to occur.
And
Well, I
it
just
isn't-
don't want our daddy to starve to death.
He's
so-
not going to starve to death. It's a natural progression. He doesn't feel like eating. He's not hungry. If
Well,
he
it's
were-
How do you know that?
Well, it's a valid concern. I mean, I think it comes up a lot. And I think that understanding sort of what happens physiologically in an end-stage disease process might help you feel a little bit better. It's likely that your dad's not feeling hunger, and that's why he's not eating. It's very common for end-stage Alzheimer's patients to stop eating, and they don't feel that sense of hunger. And we can do a lot to manage symptoms and make sure he's not nauseous and that he's not in pain and those types of things.
You guys have done a very good job of doing that so far, and I really appreciate everything you've done. They're taking really good care of him.
Well, I don't doubt that, but I still have some concerns about any intervention that might be provided for our daddy to stay alive. So I just...
Well, along with this information that I gave you about CPR, we also have these handouts about tube feeding. And I want to assure you that that up until this point, as he's declining his food, the attendants that do his personal care are always offering him ice cream or nutritional supplements that might be tasty to him, and he's just been refusing them. And they encourage him, but he's just been refusing
So
them.
it's by his choice. I've been here every day or every other day trying to get him to eat.
You've tried to get him to eat?
I've tried to get him to eat while you've been off in Atlanta.
Oh, well, that's a whole nother discussion. But anyway, I just really concerned about my daddy, our daddy, and we both love him very
We do.
much.
Certainly.
We do.
But it's obvious that we need to, JT and I need to talk a little more about what we want for our daddy, and so.
Well, and it's clear to me that you both love your father very much and that you're very concerned about him, and you want what's best for him, and you don't want him to be miserable. You want him to be comfortable, and you want his dignity to be maintained, and all those types of things. I'd like to suggest that we set up a meeting with the physician. So maybe you folks can talk amongst yourselves, and we can set up a time we can meet with the doctor to review this form that she introduced you to, this pulse form at the beginning. it's not meant to replace the advance directive that your dad has in place. It's actually meant to complement it and make your dad's wishes and your understanding of them really clear. And it's in a format that discusses CPR versus do not resuscitate. It discusses other levels of care, and like an intensive care unit or comfort care, and also this issue of feeding or not feeding. I think that it's really important to have those things down so that it's real clear in the event of an emergency that the healthcare people know what your dad wants and doesn't want.
Yeah, we don't want another repeat of what happened with Mom when she didn't have any choice. She didn't have any say.
Okay, well, this is very difficult.
It is very difficult, and we want to acknowledge that after a long flight and you've seen a condition change, that we want to be very attentive to your feelings and your brother's feelings, but the focus is really on the determination of your father and how he had explicitly taken the initiative to complete an advance directive and taken actually the burden off of you to make those decisions.
Yeah.
He has said, this is what I
Right.
want, so I'm not going to leave my kids trying to guess what I want and what I don't want.
JT and I will discuss it
Yeah.
further, and we'll look forward to the next appointment.
Yeah.
To,
Can we set up that appointment?
certainly.
Yeah, absolutely. We
Yes.
certainly can. We'll get with the doctor and meet as soon as possible.
Thank you.
Okay, thank you very much.
The key points about POLST that were just demonstrated are: the POLST conversation can include an interdisciplinary team, particularly in the skilled nursing facility setting. POLST complements but does not replace an advance directive. The advance directive names the decision maker. When there is conflict between loved ones, it can be helpful to remind them that the responsibility is to make decisions based on what the patient would have wanted. Give time for each family member to talk and to express their thoughts and opinions. The POLST conversation may take place without a POLST form actually being completed, particularly if additional input from the physician is needed regarding the patient's specific condition.